Hi, and welcome to the Borat Minda podcast, a special Malaysian podcast on mental health. I'm your host Zuleika, and this episode on obsessive compulsive disorder is brought to you by AIA Malaysia for the AIA See the Other Side campaign that aims to drive conversations on mental health, lift the lid on mental health conditions, and break the stigma. In conjunction with Mental Health Awareness Month, we would like to encourage you to pledge your support for mental health awareness and well-being. For every pledge received, AIA will donate 10 ringgit to Malaysian Mental Health Association. So you can pledge your support by searching AIA See the Other Side. Links to the pledge form can be found on AIA and MINDAKAMI's social media as well. A few months ago, we talked with Khadijah Amin about her experience living with OCD. So this time around, we bring you a subject matter expert, clinical psychologist Duska Tadic. Today I'm joined by clinical psychologist Duska. She's from Australia and she mainly works with children, adolescents, and adults, mainly with mood and anxiety disorders, right? Because that's what's really common in people who go to private practices. Yeah, today we're gonna talk about OCD, I guess, and I have a few questions for you.
Okay.
To answer. Yeah.
Yeah, great to be here. Thank you for having me.
I guess we'll just start then. Could you briefly explain what OCD is and like the kind of symptoms that come about with OCD?
Yeah, sure. So OCD is an anxiety disorder, and OCD stands for Obsessive Compulsive Disorder. So it's made up of two parts, as the name itself suggests. Someone who suffers from OCD has obsessions, and they also have compulsions. So obsessions are basically defined as intrusive thoughts or images or urges which come about frequently, and they feel really uncontrollable. They're definitely not wanted by the person. They kind of just pop into their mind and they feel like they're stuck there. Now, we all have obsessional thoughts sometimes, or intrusive thoughts. That's normal. But for someone with OCD, these thoughts will come up a lot. So for an example, someone who has a fear of contamination, of kind of getting germs on themselves and things like that, they might have an obsession or an intrusive thought of, oh no, I've got germs on my hands, I'm going to get really sick. I'll end up in hospital or I might die. So that's an example of an obsessional thought, and this thought will kind of play over and over in their mind, and it will cause significant distress to that person. So then the second part of OCD is that in order to reduce or alleviate that distress that this thought causes, the person then often engages in some sort of behaviour or a mental act to try and get rid of that anxiety that thought has created. So these is what's called compulsions. So in the example I gave before with the fear of contamination, someone might then feel like they need to wash their hands for 2 minutes straight in order to prevent something horrible happening, in order to prevent getting sick and dying. So OCD is made up of those two components, the obsessional thoughts and the compulsions. Now, someone with OCD, they often recognise that their thoughts are not rational and that they're not true, but they just can't stop them from coming into their mind, and it causes so much distress that they kind of need to do something to get rid of that anxiety. So there's a few common compulsions. I'll just give you a few examples. So
yeah, sure.
Common compulsions include things like repeatedly bathing, showering or washing hands. So that's for someone who might have a fear of contamination. Repeatedly checking things or putting things in a particular order. Repeating certain words or phrases or prayers in their mind. So these are all the kinds of the behaviours or mental acts that are common. And obsessional or obsessions or intrusive thoughts, common ones tend to be fear of contamination, fear of causing harm to someone else, fear of making a mistake, kind of fear of losing control, and even fear of certain thoughts like thinking evil or sinful thoughts. They're kind of common examples of obsessions.
Yeah, just to backtrack to intrusive thoughts.
Yes.
I know that it's kind of like a big word, I guess. Could you like explain what intrusive thoughts actually are? Because it's not really something like people commonly know about.
Sure,
or, like
sure.
understand what it is.
Yes, absolutely. And it's a really good question because we're not really trained to think about our thinking. Often we'll just notice how we feel. Oh, I feel anxious or agitated or angry. And we're not often, aware that the way we're feeling is actually created or caused by a thought that we've had. So an intrusive thought, by definition, is a thought that pops into your mind that, you really don't want there, that kind of bothers you and you can't move on from it. So we all have thoughts, right? I mean, we have hundreds of thoughts a minute. And often we're not aware of, most of those thoughts we're not even aware of. They're kind of in the subconscious. So we're going about doing what we need to do every day and we're just constantly thinking. But an intrusive thought is one that will grab your attention and it will kind of make you listen. And so you might kind of get stuck on that. So it might be, oh no, I'm going to get hurt, or oh no, something bad's going to happen. And it's intrusive because you can't just move on from it. You kind of get stuck there and you go over and over it in your mind. Yeah.
Is that different from like rumination?
Yes. Rumination, well, I guess rumination can become intrusive if you can't move on from it. Rumination is more about thinking about the past generally and going over like a scenario or an event in your mind and trying to make sense of it. An intrusive thought is more, I guess, a specific kind of thought rather than ruminating in general over a particular scenario. Does that make sense?
Yeah.
So they're similar in that you're in your mind when you're ruminating or when you're kind of thinking over a intrusive thought. You're in your head the whole time for both of those. But yeah, I guess rumination is more a broad term about thinking about the past and going over your thinking.
Typically, people think about OCD as being very like organized and obsessed about cleaning and things like that. But I know that you also mentioned fear of doing something evil. Like that sort of thought really impacts someone.
Yes.
Could you go over examples of the parts or the types of OCD that aren't as commonly thought about other than like cleaning and organizing?
Sure. Generally, OCD can present in different ways for different people. And as you mentioned, two very common ways are the obsessions and compulsions relating to cleaning and contamination. So fear of getting sick and being unclean and those kinds of things. The second most common one is about being organised and having things in order. So there's two other kind of subtypes or clusters of common ways that OCD can present. So one of them is thoughts about, forbidden thoughts. So anxiety over forbidden thoughts. So these can be kind of intrusive thoughts about that can be sexual or violent in nature. So, for example, I worked with a mother once who, she had a newborn child, and every time she was changing her child, she would have this intrusive thought that she was touching her child inappropriately. Now, deep down, she knew that this is not what she was doing and that she loves her child and she would never hurt her child. But someone who has OCD tends to give a lot of meaning to their thoughts. And this thought kept popping up for her, and she kept thinking, what if I'm sexually abusing my child? Oh no, I've touched her inappropriately. And so as you can imagine, this is extremely distressing for the mother. So, but these are common ways that OCD can present. So these thoughts that are sexual or violent in nature, so perhaps images of hurting someone badly, can be persistent questioning of your sexual orientation or sexual interest, persistent worry that you'll act on your intrusive thoughts and that these make you a bad person. Obsessions about religious ideas that feel blasphemous or wrong. So, for example, if you have follow a particular religious ideology and you have thoughts that go against your religion, you might feel extreme guilt and shame about that and kind of label yourself as a bad person for having these thoughts. So having these kind of forbidden thoughts is another common way that OCD can present. And Yeah, and the fourth subtype is hoarding. Now, hoarding is a separate disorder in itself, but commonly people with OCD will tend to hold on to things and feel a lot of anxiety about letting them go. And the difference between that and someone who has a hoarding disorder is that it's, again, about those obsessional thoughts that they can't get rid of, and they feel that something horrible is going to happen if they get rid of these things. Whereas someone with a hoarding disorder more just enjoys collecting and having those things. But someone with OCD will kind of struggle to let go of things.
Yeah, usually when, you know how there are like TV shows about like people who hoard, like extreme hoarding, I guess? And they tend to feel really anxious about, you know, people cleaning up their space or like getting rid of things, even though they have minimal space in their living situation. Yeah.
So they're kind of not able to recognise. But with someone with hoarding disorder, often the stuff that they're collecting is having more of an impact on people around them than it is on themselves. Whereas someone with OCD, it's actually more impacts them because they're so distressed about, you know, someone moving something where it shouldn't be or losing something that's important to them. So they attach that negative meaning to it, that something horrible is going to happen if, you know, they don't keep all this stuff or if it's moved.
Would you say that OCD is common in like the population, like general population, I guess?
Well, the statistics show that it's about, these are the statistics from America and the UK, that about 2 to 3% of the population tends to have OCD in their lifetime. And we don't have absolute statistics for Malaysia itself, but somewhere between 1 to 2% of people will experience a clinical diagnosis of OCD. Yeah.
Let's say someone listening to this feels like, oh, I kind of relate to the symptoms and the thoughts that, you know, the examples that you gave on OCD. Like, what should they do? Like, what should the next step be?
Well, they should go and speak to someone that they trust. I guess, firstly, you know, sharing with family or friends that they trust, to let them know that this is what they're experiencing. That can be really, you know, kind of helpful, just so that they know that they're not alone and they've got someone who can support them through this. And if it's at a point where it's significantly impacting their lives, which OCD can do because these obsessions and compulsions can take up a lot of time, you know, in someone's day, and it can affect them being able to work effectively, can affect them being able to socialise and just do what they need to do day to day. If it's at that point where it's causing significant distress and it's impacting their life, then I encourage them to go and see a professional. So a good first step might be to go to their GP if they have someone that they trust, and that GP can then give them some ideas of, you know, a psychologist that they might go to that's close by. Because psychologists are trained in kind of the evidence-based therapies, and there is a big evidence base for therapies that are effective for OCD. So I would say don't let it get worse. We know that early treatment is better and easier, obviously. So the sooner you get some help and some tips and tools to manage, the better. Yeah.
So as a psychologist, what sort of treatment is available for OCD? So generally, we know that clinical psychologists provide therapy.
Yes.
But what sort of therapy do you do for OCD, and what do you work on?
Okay. So the recommended and most evidence-based therapy for OCD is what we call cognitive behaviour therapy. In the cognitive part, we look at those obsessions, the thoughts that the person's having, and we work on helping them change their relationship with those thoughts. So as I mentioned before, you know, we don't often get trained to think about our thinking. So the first step is getting people to identify what are these intrusive thoughts, and learning that, you know, thoughts are just thoughts. They're actually not facts. So, you know, a simple strategy, a cognitive strategy that we use in that part of treatment might be getting someone to just label their thoughts and say, instead of saying, oh no, I've got germs on my hands, I'm going to die, they'll just say, I'm having the thought that, you know, I'm being contaminated and I might die. So kind of separating themselves from their thoughts and being able to look at them as an observer, that's kind of a big thing that we do. So working on those thoughts and also working on people's behaviour. So there's a specific type of cognitive behaviour therapy called exposure response prevention, or ERP, which is shown to be really effective for OCD. So basically that just involves what we would do in a session if someone came to see a psychologist is gradually expose them to the thought or the stimulus that creates the anxiety. Mm-hmm. And then we get them to learn to sit with that feeling of anxiety and discomfort without engaging in the compulsion. So, for example, we might get someone to touch a dirty surface, and obviously they would feel really, really anxious. But through us guiding them in session, we would get them to prolong, to sit with that distress over an extended period of time and not engage in hand washing, for example. And that just breaks the association between I have this thought and I must engage in this behaviour, and teaches them that actually nothing horrible will happen if you don't wash your hands 5 times or, as soon as you've had that thought. So that kind of behavioural treatment is shown to be the most effective because it's practically teaching people that thoughts can't hurt you, they're just thoughts, and you don't need to engage in the compulsive behaviours to kind of manage that anxiety. We teach them other emotion regulation strategies to be able to cope with the distress. Mm-hmm. Yeah.
I think it's really hard to imagine how debilitating OCD can be. Yeah. And you've worked with clients with OCD. Yes. And how does it impact their daily lives?
Well, it can be extremely debilitating in that, they might not be able to leave the house because they're so worried about bad things happening. So, for example, someone who has, using the cleanliness one, just because it's a simple example, a common one that most people can think of, or relate to. We all know people who like to have a clean house, right? And so we may all have at times had thoughts, oh no, my house is so messy, I really should clean up. But most of us generally will be able to leave the messy house and go to work because we know, well, we don't have time really to scrub the shower and vacuum and mop and disinfect the whole house because we need to be at work in 20 minutes. So we'll be able to leave it, and that it doesn't cause us too much distress. But someone with OCD will see that messy house and will not be able to leave it until it's clean because they really, are very distressed, and they feel that if I don't clean the house right now, something horrible is going to happen. Like I might be hurt or someone I love might be hurt. So it's really interfering in that they might miss days at work, they might not go out and, and be with friends, or they may not be able to do what they like to do because these behaviours are taking up so much of their time. Mm-hmm. And, you can imagine if you're not socialising, that can increase your loneliness and disconnection, which can lead to other problems like depression. So, there's a big flow-on effect.
Is there usually a significant event that happens before the OCD gets worse?
It can be. So we know that OCD is caused by, most likely, because we don't know the actual cause and there's a lot of research into different factors, but it's most likely a combination of neurological and biological factors. So I'll just talk about that a little bit first. Brain imaging studies and so forth have shown that people with OCD, their brain tends to kind of send messages differently. So the neurotransmitters in the brain, like serotonin and GABA and all these other important hormones that we've heard of before, or that we may have heard of, which is how the brain, parts of the brain communicate with each other. So we know someone with OCD, their brain kind of tends to function differently to someone who doesn't have OCD, but we don't know how that specifically relates to OCD. So we can't really say it's a cause, but it is likely that it does impact the onset of OCD in some way, having these neurological factors. We also know that biology can impact it. So people who have OCD are likely to have a member of the family. So 25% of people with OCD tend to have someone in a first-degree relative who also has OCD. So there is some suggestion that it's genetic. So when we look at those two factors, often in psychology we talk about having a predisposition to a particular, I guess, not a particular disorder, but a particular problem. So someone with OCD may have a predisposition biologically and neurologically to kind of develop it in the first place, if that makes sense. It's not very likely that OCD will simply start from some event that happens in the environment, although it can, but it's more likely that someone has a predisposition genetically or neurologically, and then something happens in the environment which might trigger that. So we might have a predisposition but never develop OCD, but we know that our genes and our physiology interacts with the world around us. So, often it can be due to, like, you know, an event in the environment such as something severely stressful that someone goes through, you know, some sort of traumatic event like an accident or, you know, being hurt or something like that, which obviously when you go through something traumatic, your body goes into that kind of acute stress mode, releases a lot of stress hormones, and so you're already on edge. And it's in that kind of environment that you can start to develop some behaviours to help you cope with the anxiety, which then can become quite obsessive if you kind of learn that I must do these behaviours to cope with anxiety in general.
Yeah, that's not really one specific cause.
No.
So I mean, OCD and also generally mental illness.
Yes.
As well.
That's right. But it's important for people to know that they didn't do anything to cause the OCD. You know, sometimes people can blame themselves and think, you know, if, for example, if their child developed OCD, they might think, oh, it was my parenting, I should have done things differently. It doesn't work that way. OCD doesn't develop from the way you were parented or just from experiencing something slightly stressful. Like I said, there's often a biological or neurological predisposition, and then severe stress that is out of your control often, right? You know, life throws really stressful things at us, and sometimes we just don't have the tools to cope in that moment. So we can develop some unhelpful habits. But OCD goes beyond that. You know, it's not just, you know, people shouldn't blame themselves and think, well, I should have been able to cope with this better. It is actually a neurological disorder.
Is OCD something that, I guess, the symptoms, could they be improved, and can OCD be overcome?
Yeah, it can be. It tends to be more of a chronic kind of mental health illness, but definitely not something that you have to suffer from every day. So, you know, it's just like someone who has diabetes. You might get a diagnosis of diabetes, and then you know that, well, for the rest of my life, I kind of have to be careful what I eat. You know, I can't have that cake with every time I have a cup of tea or whatever it is. So, but you can absolutely live a very long and healthy life with diabetes if you control your diet and environment. So the same with OCD. It is something that can be overcome in the sense that you can learn to manage those symptoms. You can learn to cope differently so that it doesn't interfere in your life and it doesn't stop you doing things that you want to do. There might be times where, especially in really stressful situations, where it might kind of creep up again, but that's okay, because, you know, if you have your toolkit ready of, you know, your helpful coping strategies, you can absolutely live a satisfying life.
I guess to sort of summarize, what do you think people should know about OCD, like generally? What do you think is the most important thing for them to know?
So I think it's important, like I mentioned before, for people to realise that they didn't do anything to cause this, that it is quite a common mental health problem around the world. There are many other people who suffer from these symptoms. So as a result, there is actually a lot of research done on OCD, and we have tried and tested different treatment options that have shown to be effective. So I would want people to know that they're not alone, that there's no shame in experiencing these symptoms, and that there is effective treatment out there. So, I guess to have the courage to seek out that help so that they can live a fulfilling life.
Throughout your experience, like, what have you seen that could or should change for people with mental health issues?
I think the biggest issue all around the world in mental health is still the stigma that's associated with it. And, my favourite saying, the World Health Organization actually says there is no health without mental health. Mm-hmm. And so, mental health should not be mutually exclusive from our physical health because, our physical and our mental health are really closely linked. Yet in society, we very freely talk about our physical illnesses. We can easily talk to our friends that we went to see our GP if we had a cold or we have the flu. And there doesn't seem to be any shame associated with that. If we have a sick day from work because we're not feeling well physically, it's acceptable. But a lot of people still feel that they can't be open about their mental health. So that would be, kind of the biggest thing that I think needs to change. And my hope is that we'll start to have more conversations around mental health, increasing understanding, because I think that's the first step. A lot of people actually just don't understand the symptoms and what mental health is and how, what the symptoms are of the different issues. But the reality is we all have mental health. Mm-hmm. And I went to a talk recently which reminded me about the fact that illness and health are actually not on the same continuum. So we can have a continuum where we have mental illness. So on one end there's no mental illness, on the other end there's severe kind of mental illness. And then we have another continuum which is health. So we might have poor health all the way up to really good health. So someone who has, let's say, a diagnosed mental illness like depression or anxiety they can still have really good mental health even though they have a mental illness, because mental health and our well-being is not static, it's dynamic, it changes. So on any one day, I could be having a really great mental health day today and just be feeling really positive and have lots of self-confidence and happy, and tomorrow I might wake up and just feel like the world's on top of me and it's all too hard. So we all go through that, good and bad mental health days. It is very possible for someone who has a mental illness to have really good strategies and coping mechanisms so that they can actually have good mental health overall. So knowledge is really important. We need to be talking about it so that people understand the symptoms, not just for themselves, but for other people, so that they then, understand what other people are going through and how to help as well. Because we could all benefit from learning about ourselves and improving our mental health.
Yeah. That's kind of like a nice segue towards our next episode.
Yes.
On how to take care of our mental health. Thank you so much, Duska, for sharing with us what OCD is, and especially from a clinical point of view.
My pleasure. Thank you.
Thank you for listening to the Borat Minda podcast. This episode was brought to you by AIA's See the Other Side campaign. Remember to visit their website to pledge to support for mental health awareness, as AIA will donate 10 ringgit to MMHA for every pledge received. You can listen to the Borat Minda podcast on Spotify, Apple Podcasts, and YouTube, as well as keep up to date with us via Twitter, Instagram, and Facebook, and the handle MINDAKAMI. If you'd like to learn more about AIA, one of Malaysia's leading insurance providers, visit aia.com.my. I'll see you on the next episode on how to take care of our mental well-being.